Sabah. And we'll have a lot of their experience right now. We'll start our panel with a common quote I always use: there is no right and wrong. The hardest decision is in life are not between good and bad, or right and wrong, but between two goods and two rights. Okay, we'll start with one issue now. The debate is when tissue is an issue. If you are going to do refractive surgery, what's the most important parameters when dealing with pachymetry? Is it the preoperative corneal thickness? Should be more than 500 microns, a golden number we always use. Residual stromal bed should be between 250 or 300 microns. Residual stromal bed, of course, is calculated. Is the difference between the corneal thickness minus the flap thickness and the ablation depth. Some this should not exceed 50%, the nominal residual stromal bed. Marconi Santiago and his colleagues postulated that the PTA, or the percentage of tissue altered, shouldn't exceed 40%, which is the flap thickness plus ablation depth divided by the corneal thickness. And the last one is the biomechanics. Let's start with Professor Mazen Singab. What do you think about the pachymetry when you're assessing a case going for refractive surgery? Which is the most important item you look at? The initial pachymetry, the residual stromal bed calculated, the PTA, the biomechanics?
Very good. I believe in God and PTA.
PTA. So you don't look at the initial pachymetry?
Yeah, of course I look. For example, if I want to do LASIK, it should be more than 500.
So you respect the 500
yes,
rule?
limit. Yes.
Okay.
Yeah. And I don't look for the residual stromal bed because when you consider the PTA, for sure the residual stromal bed will be more than even 300 in most cases. Biomechanics, if I'm lucky, I will have the biomechanics in my clinic, but still till now, no. So I consider the pre-op, I consider the PTA.
Okay. Dr. Hosni, do you agree with Dr. Mazen in this condition?
I totally agree, but I think these are all like elements of, or components of a recipe. Sometimes each one of them is much more important than the other. It all depends upon the type of the patient, the amount of refractive error that I'm going to treat, if it is myopia or hypermetropia, if I'm going to have...
We are talking here about myopia because when tissue is an issue, usually in myopia, not on hyper.
Yeah, but I mean, for example, if I have a patient like 490 microns, central pachymetry at thinnest point, and everything is absolutely fantastic, and the cornea is superb, and I'm going to do a correction for a minus 1.5, I'll go ahead and do a femtolacing. I will not stop because it's 490. So, but again, I look at the same parameters but differently according to each patient.
So the PTA is the most important.
PTA. If you respect the PTA, you're home and dry. Everything will fall into place.
Okay, Dr. Ahmed, if you have a patient 480 micron and he's -1, and he wants to correct this -1. So you respect the residual stromal thickness, you respect the PTA, you respect everything. Would you go for 480 initial pachymetry? Everything is fine, everything is normal?
Yes, my cutoff limit is 460.
460?
460. My cutoff
LASIK or
PRK?
PRK.
PRK, of course. Hopefully not. No, not that 500, not like different.
Let me just add us. I know we're going this way.
No return.
I'm sorry about
45 minutes. Okay.
Okay. Last week, I had a patient. She was 25 years old. She had a myopia of -1.75 in both eyes. I tried as much as possible to find anything wrong in her cornea. She is a pristine cornea. I sent her to do Corvus. Her Corvus is very good. The TBI, the CBI is very good.
What was the initial pachymetry, sorry?
520.
520.
Okay, yes. The only thing is that her father, I did one eye intracorneal rings and the other eye penetrating keratoplasty for keratoconus 15 years ago. I tried as hard as I can to find anything wrong with her, and there was nothing wrong. I did her PRK. 520.
Mustafa, if you are facing,
You have to do PRK.
okay. Dr. Mustafa, if you are facing a case like this, if you have a look on this pentacam, and Dr. Karounis too, because we'll discuss this case with you, it's almost 480, the pachymetry. It has a -1.5 astigmatism. everything appears normal, posterior elevations, anterior elevation, the pachymetric values. When you do refractive surgery for this patient,
Just show us the other eye.
it's the same, exactly the same.
Exactly the same.
Yeah.
Correction,
Minus 1.5 astigmatism, corrected to 1.2 or 66 of 2020.
The biomechanics.
Biomechanics, okay, is a good option. Okay.
Yeah, I would do femtolasing.
We'll do
470
50.
So 480.
480?
Thickness.
For 80, I'll go for PRK.
Yeah, okay. Dr. Caronis, would you accept the PRK in astigmatism in this case?
can I go back one step and ask to the list of the ingredients before going to the areas of topography,
Yes.
age,
Mhm.
and history?
Yeah.
Because I think that a 40 years old
She's-
patient is totally different from a 20 years old
She's
patient.
22 years old.
All right?
Uh-huh.
In history, we know that there is nothing. right?
Nothing significant. No family history, no robbing, no anything.
All right, so if all parameters are okay, this case is suitable for lamellar surgery as well. I mean, I would not be concerned with doing LASIK as well.
So you can do LASIK for this case.
Yes, because the PDA would still be more than
We're
acceptable.
talking here about femtolasik, of course,
Yes.
because here it's, yeah, I know, but because there are a lot of people here are still doing microkeratosis LASIK. When you,
Right.
when Caronis says LASIK, it means
Femto?
Yes,
femtolasik.
femtolasik. Let me say this also.
He doesn't have a microkeratosis.
I think it's useful to know that I had, as everybody, cases with, ectasia, and we know that besides all the, clinical features, parameters, diagnostic tools, and all that, that really improved our diagnosis, the femto-LASIK, the use of a femto reduced the risk of ectasia by many times. So I think that femto-LASIK is the standard of doing it. But I would not be concerned doing femto-LASIK in this case. I mean, if all parameters are fine, the thickness as itself will not be a driving factor.
So we have 3 PRKs, 1 femtolasik, no touch
For this patient?
for this patient.
Great. Now, thank you. In North Africa and Morocco, when I discuss these issues with them, definitely they say we are different because their corneas are thin. So even their cutoff values for the PRK is 450, not 470. And they do LASIK below 500 because their corneas are thin. So geographical distribution, population should be considered as well. But for me, no.
No, but if you have this is a bad D of this patient, it's normal, and if you have corvus for this patient, it's perfect. Would you change your mind after seeing this corvus, or you're still having the 400, the 500 micron limit for you?
No, I may go below, yes. I agree. For example, if the patient is 490, okay, and -1, -2, I can go, since the biomechanics are good, I can go for femtolasik.
Femtolasik.
Femto.
So the moral of the story is that Dr. Mazen specifically changed his whole mind after knowing that the biomechanics is perfect.
Yes.
And this patient, by the way, was referred from a lot of surgeons who refrained to do any sort of refractive surgery, even PRK, because of the thin cornea. But I did her a PRK, this is what I did actually, after doing a corvus, and I'm happy knowing that the biomechanics is good. So the biomechanics is the new player right now. It's not just the residual stromal thickness, the PTA. You have something that reassure you that you can go for surgery, and at least for medical legal, So if anything happens, you have a document that's okay. Let us accelerate the thing. Very thin cornea. It's 430. Okay.
Again, age, amount of correction.
He's 30, almost 30. He's a male patient. The amount of correction is -2 sphere, -1 cylinder, correcting to 6 or 2020. This is a beta cam for the patient.
Can we see the profile?
Slope.
Fitness profile. BAD.
Progression in the curves, yes.
But we all know that the progression curve would be different because it's outside of the limit, because the limit of the profile or the whole regression analysis that done in Pentacam, it was from 450 and below, so it's outside of the profile, so
Yeah,
it will
no.
exhibit a different curve.
Yeah, I look at the shape,
Yeah, I
look
know.
at the location, the
Yeah.
shape, whether
Yeah.
it is consistent with the black dotted or not. But it is high average. Many indices are abnormal. So for me, I don't.
Okay. Would you do cross-linking for this case? Do you consider this case a keratoconus?
No.
It's just a thin cornea.
It's just a thin cornea. So we have an entity called very thin cornea, which is normal, and you don't have to do any sort of cross-linking or rings or whatever. This is not a keratoconus. It doesn't mean it is a thin cornea. It doesn't mean this is a keratoconus. But would you do refractive surgery for her?
Sure, phakic iris. Phakic iris.
Phakic iris,
Yeah.
but you don't touch the cornea.
No, I will not touch the cornea, I will implant a phakic iris.
And please keep patient under follow-up.
Of course,
Yes,
I'm
and
following
then you
you.
have to do the pentacam.
Yeah, for sure, for
How
sure.
about PRK extra for this?
No,
No.
no.
Let this be at the end of the, because I have,
Which is
Okay, okay.
I don't do this.
Extra.
actually, I don't have a timer by the way, so I might end up at the midnight or the gala. So I don't have a timer, so it's your responsibility. Okay. Hyperopia.
دكتور طارق بس الحلقه اللي فاتت دي بس المشكله هي الثين كورنيا ولا المشكله في البايوميكانكس بتاعتها؟
There is no biomechanical study for this case. I don't have the biomechanical study for this
لو
case.
كويسه حضرتك برضه not touching.
I will not touch because this is an extreme case. This is my record, by the way. This is the record.
I have a case similar like this.
Yeah, I know.
But I
Everyone
did-
has
I
a
did-
case like
I
this.
did for it to smile.
No, no,
Then
no.
film was black?
Yes, yes. And now around 7 years, the patient is still stable.
Lucky you.
Yes.
Okay.
Please
Lucky you. Lucky you.
don't do it again.
Okay.
Femtosmile is not an excuse to do thin corneas.
But
Femtosmile is a
I have a
I
comment.
tell my experience. Okay.
I know, but I'm experienced in the femtosmile more than 15 years now. Again, femtosmile is a refractive surgery that we should respect every aspect as refractive surgery. I don't do femtosmile below 460, 470, 430 is not touch. Please, you are very lucky.
Ectasia is a multifactorial process. So if we do refractive surgery for this case, we are just increasing the risk of ectasia. Might be 20%, 30%, but the patient may be lucky, maybe in the 70% of will not develop ectasia. I remember there is a paper in GCRS was talking about doing refractive surgery for thin cornea and follow up for long years, and nobody exhibit any sort of ectasia, but this is not the rule, actually. Okay, hyperopia. A flat cornea, if you have a hyperopic patient, you're happy that you're having a flat cornea because what you are intending to do is steepening the central cornea to correct the hyperopia. So if the initial cornea is flat like this one, it's 39.5, 40. So how much diopters of hyperopia can you correct for such a case? I know there are some rules in some countries that restrict for 4 diopters in Germany and stuff like this. But if the patient is asking to correct 6 diopters of hyperopia in this case, and it's flat, we know that each diopter of hyperopia is converted to 1.2 diopter on the pentacam, which means that the 6 might be 47, something like this, which is accepted prolate cornea after the operation. How many diopters were you correct, Dr. Mazen?
Great. I consider the KM, as you said, but as well, I don't go more than +4.
+4.
Why? Because usually the optical zone is 7 millimeter.
Okay.
But you will not get 7 millimeter optical zone after the operation. After 3 months, if you capture the patient, you will find it about 6 or even below because of the shrinkage, because of blah, blah, blah. The higher the number that you treat, the smaller the efficient optical zone that yes, exactly that you will get. So we are creating, if we go above +4, we are creating something similar to keratoconus.
Yeah.
Of course, the patient will be very happy if they are in the presbyopia age because we are creating
Negative spherical
aberration. But at the same time, they will suffer a lot during night and driving and so on. So above +4, I don't go, regardless of the KM, if it is still within the normal range.
For Hosni, this patient has a relatively narrow pupil, it's 3 millimeter. Would this encourage you to correct more than 4 diopters?
I've started doing LASIK for hypermetropia in 1997 because this was my PhD thesis. We compared LASIK and whole ectomy keratoplasty and hexagonal keratotomy, 3 arms of the same study in correction of hypermetropia. And I've been doing hypermetropic refractive surgery ever since. And my advice to everyone, do not go above +4. Never.
+4 is a golden number.
Yes.
Irrespective of the initial status of the cornea, how
Irrespective,
flat is the cornea?
the thing is, we actually we aim at centering our ablation around the visual axis, which we cannot do. So we measure the cord nu, and we try as much as possible to do things much nearer to the vertex of the cornea, hoping that this is very near to the visual axis, not the center of the pupil. And then these patients will end up with a keratoconic-like so they will. This is a very, very hard, a very large or very strong stimulus for dryness. So these patients they always have at the tip of the cornea very dry, and the tube film is not stable. And you have a bunch of reasons to avoid doing a ginormous donut-shaped ablation on the cornea. So I think that the safety limit is +4. And up to this very moment, I'm not very happy doing a +4.
Yeah.
I do the +4 and keep my fingers crossed. So I will never go beyond +4 in a corneal ablation.
Dr. Ahmad, you're having a good femto LASIK machine that allows you to have a wide flap like 9.3 diameter, and you have a good LASIK machine that allows you to have a wide optical zone, and you have a customization that leads to proper centration of your profile. And as you can see that the angle kappa is not that huge in this case. Would you correct more than 4 diopters?
No, never ever more than 4 till now. And still telling the patient that the order ablations are definitely worse than the myopic ablations, and definitely the quality of vision will be not as you expect. It's very important one, especially for type A personalities who are highly demanding. They want to drive at night with a +4. Definitely, as Muhammad said, you are inducing steepening and as if you are doing keratoconus. So please, not more than +4 up till now. Nobody knows what will happen next.
Dr. Busra, do you agree with the number of the +4?
Well, I used to do hypermetropes, and the largest I did years ago, wife of my friend, and this was +6. At that time, the machine couldn't put in the machine the whole refraction, so you have to do it in 2 sessions. So this lady, she is now like
They're still married?
52, I guess. No, she was happy actually, because she was, when I did it, she was like 35, and she had a regression, of course, of +2, but she could see in the morning, and getting in the presbyopia age, she wore glasses. The thing that she took my advice, and she wanted to do a blepharoplasty. So I referred to Dr. Aranya, and she wasn't happy at all. So the problem wasn't in the refractive, but
Okay, that's good.
this one thing. The other thing that I did +2 and +3 and +1.5, and in different ages. Actually, also even in like 45, they do have regression. So again, after 1 year or 2 years, they will again need glasses for this. So for me, actually, my consistent now is I don't do a pro, because the patient will always go. Yes, this is my conclusion now. I don't try even to have hypermetropes, because somebody else will take the burden of discussing with the patient the recurrence, even the loss of having bad quality of vision, especially if they are in vision. So doing the hypermetropes, I wait for them until they get like 42, 45, and then we do.
As Blas said, would you consider doing clear lens extraction and multifocal IOL for a patient is 30.
No, no. I have a rule as regards refractive lens replacement. I like to do it. It's one of the most powerful procedure I have in my portfolio. But as long as the crystalline lens is still accommodating, patients do not like the artifact vision they have through any kind of.
But the patient, had +7 diopters and he's upset. This is,
Oh, come on. If he's 30, he's going to accommodate still a lot. So maybe he's not able to bring his accommodation down to plano, but for intermediate and near, with the distance correction, he or she can still have the whole range of vision. That's the point. So my cutoff age for a refractive lens replacement is more on is the crystalline lens still accommodating? Is it still having at least 2 diopters of accommodation? If the crystalline lens is still more than 2 diopters of accommodation, I do not do the procedure. If it is less than that, I'll do it.
And what's the golden number for keratorefractive surgery for hyperops?
+4 as well, but again, not only because of all the reasons they were mentioning, also because you cannot achieve more than 4. It's not a matter of regression, it's more a matter of epithelial remodeling. Whatever you're going to do, the epithelium is going to fill this huge donut-shaped area and produce a refractive regression. So even if you attempt to more, you'll end up with never more than 3.5, sometimes 4 if you're lucky.
So, Mazen?
Just one comment. Do you have the ICL for hypermetrop as an option for you?
Yes.
I have, yes. This is
This
the
is 2.7. This is 2.7.
Yes.
Yes, in general, yes.
In general,
But again, please, I'm stressing on the ICL for the hyperops, the anti-chamber depth should be 3, not like the myopes. Myopes is permissible up to 2.8. Like for the hyperops, it should be 3. It is here internal 2.7. So ICL is okay, but with the minimum
So,
anti-chamber.
Mazen, comment?
Yeah, a quick comment. We have to be careful when we do partial treatment for high hyperop by lasers, because, for example, if a patient has +7 and we do +4 just to reduce,
Okay.
maybe we will trigger trophy. Maybe the patient, yes, maybe the patient will develop a diplopia and strabismus because it was compensated by no accommodation, because very high hypermetropia and the patient is not accommodating properly, so
Yeah,
will
good
be
point.
hidden. So always in hypermetropia, either for LASIK, for refractive lens exchange, for ICL, for whatever, proper muscular study should be conducted.
Very good point. We start with Dr. Karumes for a change. Yeah, for a change. Because okay, we will discuss another debate, that enhancement, when and how. Because if we have a primary procedure, for example, you have a patient with a PRK, LASIK, keratorefractive lenticule extraction, which is a new name purpose for SMILE and similar procedure. And you are going to have an enhancement for this patient, and you can choose between PRK for whatever. If you have, for example, LASIK, you do PRK. If you have a PRK, you do PRK again. If you have a PRK primary, would you do SMILE for this patient? Would you have LASIK after LASIK, and how will you do it? And if you have a SMILE, would you do SMILE? Would you do PRK? And when you start to consider enhancement.
All right, so let's not consider patients who may have had a treatment in the past and they show up maybe years later, because these patients had an indication that probably was different than what you would do today, right? So if it is something that happens today and the enhancement is something related to regression or whatever, so something that you may consider in the short term period, my rule of thumb is stay with the original procedure. So that if the patient had a reason for having PRK, the patient is going to have PRK. Same is for LASIK, same is for KLX. So I would stay in the same.
So if you have a SMILE, you would re-SMILE?
Well, it depends, because SMILE, it depends also the laser that you're using. Because I don't know what is available here besides the
Everything.
can you use the Elita? Can you use
We
the?
don't have Elite yet, but we have
Dr.
Smile.
Coronis has an elite.
Yeah, I know.
There's a
Yeah.
few centers that
Yeah.
have, so yeah.
So can you use like the Atos? Is it available here? The Schwinn, the 52nd laser?
I don't know if Dr. Masri and Dr. Atos is in there.
No.
No, we haven't. We
Right,
don't have it
so-
yet. We have FS 200. We have the.
No, I'm talking about laser able to
Visual
provide
extraction,
to
so
perform
yeah,
KLEX.
that's right.
Lasers able to perform KLEX.
Zero
Only
max,
one.
only
Only
Visumax.
Visumax. Okay.
Zero max only.
That's a part. In Europe, some of these femtosecond laser able to provide the KLEX have also good software for cutting the flap again.
The Visumax has it.
Circle model.
Yeah. So in case of a KLEX procedure, I think it's reasonable to go through LASIK if you have that software, basically. Rule of thumb, I would wait at least 2 months after the primary procedure
2 months.
for LASIK and the smile. I would wait longer for PRK.
How long for PRP?
I would say at least 6 months.
At least 6 months.
Yes. There is also another reason, another point to consider the amount of correction, because we know that higher corrections lead to a longer time to stabilize, especially because, again, it is a remodeling. So I would wait for as long as the refraction is stable. As I said, rule of thumb, 2 months for LASIK and KLEX, and longer for PRK.
Dr. Mustafa, you have a patient in your clinic who performed PRK 5 years ago, and now he's minus 1.5, and he's seeking enhancement for his procedure. What sort of operation will you do for him?
Well, I have never done PRK after PRK. So my experience, this is limited. But if he's LASIK, of course, we can raise the flap and do
Would you do LASIK
enhancement,
after PRK?
very early as 1 month.
Would you do LASIK after PRK if the patient already?
I've never done this.
Dr. Ahmad, you have experience with this?
I like the PRK, especially in all enhancements.
In all enhancements?
Yeah, even after SMILE, which
Okay.
is very few, but I'm doing PRK. The point is for LASIK patients even, as I'm telling them, raising the flap or having another flap will have epithelial downgrowth of more than 30%. That may need to shift to the transepithelial PRK. It's perfect, just all with laser. The laser will remove the 50 microns, and then you can do your PRK, which is usually -1, -1.5, not more than that. Because this definitely what the cornea will permit. If it's more than that, I'm looking for the ICRs.
Using PRK over LASIK flap used to be a taboo in the past because of the excessive haze that could occur. But after mitomycin, the story is totally different. But and some people are preferring doing PRK on the LASIK flap not to affect the biomechanics, because already the flap is not calculated in the biomechanical properties of the cornea anymore. So you're preferring PRK rather than lifting the previous flap.
Yes.
Would you do the same, Dr. Hosni?
It all depends upon when was the LASIK done, because some of these LASIKs have
15
been
years
done
ago.
15 years ago.
Okay.
Now, it is never, actually the most exciting thing about this procedure is elevating or lifting the flap, and we have lifted the flaps. Yeah, it's nice, it's nice, I know. But some of these flaps that were done with the good old Hansatoma, the ACS, are like 250 on OCTs.
Yeah.
So I wouldn't suggest that you lift the flap, even if you can, in a very, so I do OCTs for everyone who had. I do 2 types of OCTs basically. I want to know the thickness of the flap, if it is done pretty much a long time ago, and I do an MS39 if this patient has a PRK, because the -1.5 might be all epithelial. So I really want to know the profile of this patient. I would do a surface PRK in thick flaps. Okay, I do not like to ablate to the interface. So if my ablation would go to the interface, in my experience, I mean, I've had patients that are absolutely fantastic after I've done that, but the patients that developed haze after doing a PRK on top of a flap, most of them are the patients that you ablated until you found, you know, the edge of the flap But again, it all depends from one patient to the other. It all depends upon the primary surgery, because sometimes if you are going to do a PRK, then definitely do a transepithelial PRK, because if you're going to use manual techniques to elevate, to remove, you can sometimes discover that this flap had wrinkles before, and it wasn't a very smooth.
Very common.
Yeah, very common.
And the epithelium was masking it.
Yes, and the epithelium was masking it,
Yeah.
so you do a transepithelial PRK. I mean, it all depends from, and then deciding which ablation would you use, which profile would you use, with front-guided ablation, would you use topography-guided ablation, would you standard ablation? It is all different from, I always say that the redos are not, touch up. So because a lot of people there, I have like 3 cases of LASIK and 1 touch up. So it's not like this at all. This is the most important case of the list, and this is the most difficult decision of the list.
Dr. Mazen, you have a nice young woman. You already did PRK for her, and after 1 month, she still have some residual error, and she's not happy. She's complaining. I can't see well. I can't drive. I can go to my school or university, and now she wants a visual rehabilitation. She did PRK, and after 1 month, you still can see that she has like -1 of residual sphere. Would you go ahead and do her another PRK, or just wait until you see the remodeling and final results of your operation?
Very good. Counseling the patient before the operation
Before the
is the
operation.
most important.
Yes.
I tell the patient, if we have any residual refractive error, we should wait 3 months. And it will be for free. So they smile. First they do like this, and then they smile, because it is.
They smile or do smile?
So for me, I know. Some patients may come, they start complaining, I have headache, I cannot see, I blah, blah, blah. I told you. I told you. And anyhow, I ignore. And by the way, after 1 month, I may do cycloplegic refraction to see whether it is something accommodative spasm or something real. And I may advise the patient, please use glasses. Doctor, I did the operation to get rid of glasses. Yeah, of course, it's up to you. We have to wait 3 months. I'm very strict with this.
Same goes for LASIK.
Yes, even for this.
So, but you are not worried.
No, sir?
Are you worried when you have like -1 after 1 month of LASIK?
Yes.
I say
Of course, I will be
the
worried.
same way like PRK, because when you know the PRK, the wound healing is totally different, and it takes time for remodeling of the epithelium. But in LASIK, you're expecting to have the result faster.
Yes.
So if you have like after 1 month, I know you should wait.
In most cases, after LASIK or even after SMILE, if you find myopic shift after myopic treatment, it is because of dry eye. And if
Yes.
you do epithelial mapping, you will find epithelial hypertrophy. So it is something false. So maybe I will go for punctal plugs, and maybe I'll go for too much lubrication, cyclosporine, whatever. 3 months, and then we take the decision.
3 months.
3 months. And let the patient go and complain to the Ministry of Health.
Okay. We're going to shift a little bit to keratoconus now. A long debate. Laser for keratoconus. He's not here, unfortunately. Okay. We know that cornea in keratoconus has a biomechanical error, and this is somehow attributed to the thinning of the cornea. So removing tissue from thin cornea or weak cornea will definitely have some sort of biomechanical weakening of the cornea. This is a concept, but now we have a lot of issues about laser for keratoconus. For example, I'll give you one example. This is a patient with -1.5 diopter of astigmatism with 0 sphere, just -1 point. This is a keratoconus, classic keratoconus, and the other eye is more advanced than this one. So she wants to do cross-linking. The pachymetry is fine, it's 530. And you're going to do cross-linking for this patient. Would you consider do some laser touch-ups during the cross-linking to correct the minus 1.5 sphere, minus 1.5 cylinder to regularize the cornea during your cross-linking procedure or pre or post cross-linking procedure. We have a lot of options. Some people claim that PRK alone is a cross-linking procedure. Some people claim that PRK with CXL, like Athens protocol. Some people say PTK with CXL, like Cretan protocol. We have LASIK extra. Can we do LASIK extra for this case? Can we do SMILE extra for this case? SMILE doesn't affect the biomechanics, you know. SMILE is a magic solution for everything. And if you're going to do this laser treatment, even pre-cross-linking or post-cross-linking, what you do is customized based on wavefront, topography guiding, the new ray tracing, selective higher order aberration treatment. Would you do laser for keratoconus in general or not? We'll start with Francesco Caruanis, the Italian version of us. Would you do laser for keratoconus?
The general answer is no.
No.
With exceptions.
With exceptions. What are the exceptions?
Exceptions are age,
Okay.
need of cross-linking.
Mhm.
So if I'm planning for a case like that,
Mhm.
who is relatively young, I would tell the patient, we do cross-linking today, I
Mhm.
mean full cross-linking, not extra.
Okay.
We wait a few years and then we'll eventually reduce the amount of higher aberrations that you have
With?
with the laser treatment. But I would say 3, 4, 5 years later, once we have the stabilization of the potential progression. But again, this is an exception. It's not the rule that I would consider. So my rule would be no. Yeah.
If you're going to do the laser after 3, 4, 5 years, which is stable cornea, biomechanically, stable with pentacam, or whatever, Corvus or whatever, which type of customization would you use here? Wavefront, topography, ray tracing, select by order, or whatever?
In most of the cases, that would be a transepithelial,
Transepithelial.
because any kind of information that you may get through wavefront or topography is biased by the thickness of the epithelium, and we know that the thickness of the epithelium changes quite a lot. So if you're going to reduce the amount of higher aberrations through an ablation, the epithelium will not rebuild upon itself in the same way. So I would try to smooth down the amount of higher aberrations through transepithelial ablation.
So it's a pity thing.
Yes, somehow, but again, every case is different, you know what I mean, right? Because you have to evaluate the thickness of the epithelium, the amount of distortion given by the conus before taking a decision. But I would not enter just the topography data, because you may end up with a significant overcorrection. Exactly.
So Mustafa, laser for Casey, what's your opinion?
Laser for?
Casey, in general, for keratoconus.
No, I don't agree of laser for, okay, although in the early Athens protocol I did some cases, but I stopped doing this because I have a problem also of insulting the cornea with two laser and cross-linking. For now, there is a lot of new data coming on with the selective eye order treatment, and all this I think we will rethink about doing correction with this.
Laser for Casey?
No, I do not agree for doing laser for.
Smile extra?
No.
Why?
No.
It's nice. It's extra. You can have some extra.
This selective patient
Huh?
would benefit from cross-linking, which mostly this 1.5 cylinder will improve without any
Yeah.
cross-linking. You know, it has a flattening effect, and it may correct the refractive error. And again, I do not believe in any extras. Neither LASIK extra, neither SMILE extra, no extras at all, because the extra is something just to let you relieve that you did something to protect yourself, but it's nonsense. You are not doing cross-linking. You are putting just some riboflavin on the top of the cornea after removal of the flap on the stroma, and then just for a few minutes, which is really no evidence-based medicine for any extras. So I do not believe in any laser for keratoconus. There is no role for SMILE in keratoconus at all. There is no extras.
Dr. Hosni, this patient is, by the way, the previous patient. She's your patient. You did her cross-linking 5 years ago. She's on regular follow-ups every 6 months with a perfect pentacam, stable pentacam. And now she's annoyed with the aberrations right now, annoyed with the astigmatism. And she's asking for some sort of selective...
Why didn't she come back to me?
She's your patient.
She's my patient?
Yeah.
And she came back to me?
Yeah.
And not you?
No.
Now
I'm just the topographer.
okay. Now, of course, I beg to differ with all of my professors here. Laser vision correction or surface ablation does have a role and does have a big role in keratoconus, especially in early keratoconus where patients are continuously complaining from the quality of the vision, even if the quantity is good, even if they see 0.7 or 0.8, that the quality is not that good. And when you do aberrometry or you do, you know, a good tomography and take a look at the anterior surface of the cornea, you'll find all sorts of bizarre, especially coma, especially vertical coma. So these patients are suffering, and we should believe them, and we should service them well if we can. Now, I think in these patients, step number one is to cross-link them. And this is the safest thing that you can do. And when the patient does the cross-linking, he's home and dry, he will not progress. And the cross-linking itself will change the pattern of the higher order aberrations a little bit. Of course, it does not cause that much of a flattening in this subcohort of patients where they are only starting to get keratoconus. The big flattening that happens is with the high Ks and the thin cornea.
Of course, yeah.
But in this patient, you will find some degree of flattening, but a totally different higher order aberration profile 6 months after you've done the cross-linking. And if the patient decides then that the quality of vision is not bad, then what we went through different eras of treating these patients with the wavefront guide ablation, then with the topographic guide ablations that we were not allowed to call contour, and then by the selective higher order aberration. These patients, sometimes you ablate as low as 10 microns of selective higher order aberrations for just vertical coma, and the life changes, and they see very, very well. And you do not ablate, you do not remove cross-linked cornea and stuff. And so the thing is, each patient should be studied separately, but the concept of using your excimer on an early keratoconic patient is there, and I think has a place in our practice, and we benefit a lot of patients from this type of service, basically. Just a quick note, there is compelling evidence that LASIK extra does make a difference, and Cosimo Mazzotta has like 325,000 papers showing demarcation lines. Okay, so it does do something, but not that much. I believe Cosimo.
Dr. Mazem,
I believe Cosimo.
Dr. Mazem, if you have a ray tracing machine in your facility,
The IBIS.
if you have a ray tracing machine in your facility, would you be able to correct this cone?
I agree with Dr. Mohammed Husni what he said, but not LASIK. I agree with the first part of his speech. So I do cross-linking first, I wait 6 months, and then I do wavefront guided treatment to treat
After 6 months?
After 6 months. Selective coma, not spherical aberration.
Yes.
I don't touch the spherical aberration, just the vertical coma. And with the ray tracing, of course I don't have experience with it, but it seems that it is much more accurate and precise, so it will be even much better. But if the patient is happy with glasses, why to touch his cornea? If
No,
he has
we're
-1,
talking about unhappy patients, by the way. Of course, if the
unhappy
patient
because of what? Unhappy means
in the morning, I was talking about no treatment for keratoconus.
Very good.
Yeah, I know. Of course, if the patient is happy,
No.
don't touch him.
Even they are not happy. We have to understand why they are not happy. Maybe they are not happy with the glasses, not
Yeah.
because of the high order aberrations.
Yeah.
If they are not happy with the glasses, we will say no. You have to be happy with the glasses, and that's it.
So this is a very good point. When the patient complains, you should correlate his complaint with something that you see. So if he's complaining of too much ghosting and he has too much vertical coma, then it fits, then you can treat him. But if he's complaining and he doesn't have that much of a heart rate aberration, then exactly, wear your glasses.
And in the morning I was talking about that doing glasses for keratoconus is not an easy task at all, because autoref is misleading all the time. You should try the axis of the autoref, the axis of the coma, the axis of tomographic astigmatism. Let the patient choose the manifest refraction. You put a lot of effort to have good glasses that the patient can depend on. Because I have seen a lot of cases that has glasses written directly from the autoref with an assistant and something like this, and the patient is not happy, of course, with glasses. But if you just put some effort in good prescription, the patient might be satisfied.
The best investment is to train someone very good, and then leave the patients for him. Train a person, honestly, train someone very, very well, then give him all.
You can ask my fellows what I'm doing for them. There is a challenge that they improve lines for keratoconus.
Okay.
if I improve them more 1 line or 2 lines than the glasses he prescribes.
I have a comment regarding the glasses for patients. If I see a patient not in the progression age, we are not talking about progression to do cross-linking. Now he has stable cornea because, for example, he is 40. Good? And he has variable access from time to time. They sometimes come with plenty of glasses.
Yes.
All of them are different in access. In this case, this is an indication to do cross-linking for the patient, although he is no progression. In order